All right, I see people are still joining very rapidly. So welcome everyone to our seminar today for the Agency of Healthcare Research and Quality. My name is Dean Sittig and I'll be your moderator today. And we're going to be talking about lessons learned in the real world on applications for patient-centered clinical decision support. And we're certainly sorry for the delay in starting. We had some technical difficulties, which is just the first half of this presentation. The second half will be discussing the difficulties we had with our patient-centered decision support. So thank you very much. If we go to the next slide, none of us have any disclosures or conflicts, and I'll go over who's who in a second on that. Next slide. So our agenda today is to talk about the Agency for Healthcare Research and Quality's Patient-Centered Outcomes Research Clinical Decision Support Initiative. We'll also be discussing the current state of clinical decision support standards as they relate to patient-centered outcomes research. And then we'll talk about most of the talk will be on lessons learned from a pilot study that we've been conducting with our colleagues at Yale. Next slide, please. In terms of our, that's our welcomes and introduction. We go to the next slide, please. So our speakers today will be James Swiger from the Agency for Healthcare Research and Quality. He's a health scientist administrator, and he's the director of the project from their end. We'll have Aziz Boxwala, who's the president of LMU Informatics and a longtime contributor to the field of medical informatics and a good friend. We have Neetu Kashyap from Yale University, who's the associate chief medical information officer and the clinical director of this project from the Yale side. And we have David Lobach, who's also a vice president at LMU Informatics, and he will be talking about more the technical sides of the project that they did at Yale. Thank you so much for joining again. And if I go to the next slide, please, we'll review our learning objectives, basically to understand the current state of standards and how we're going to collect this data and use this patient-centered, patient-generated health data for clinical decision support. So this is sort of a new type of data we're trying to use. We're going to try to learn how that decision support can be used to support healthcare delivery, hopefully efficiently, monitoring patients remotely and collecting some of this patient-generated data with an overall goal of reducing clinician burden, which is a hot topic these days. And then finally, we're going to learn some of the challenges that we've encountered in this early phase of patient-centered decision support about electronic health records, and then some of the limitations that they have integrating those systems together at Yale University. We could have our next slide, please. So just to make sure everyone's on the same page with patient-centered clinical decision support, this is sort of the next phase of clinical decision support as I see it. And it's really to support individual patients or patient populations or their caregivers. And it uses one or more of the following factors. The first is knowledge that's generated by the Evidence-Based Research Center, the PCOR Evidence-Based Research Center, and their continuing comparative effectiveness research. And so that's a sort of knowledge that would be used to drive these decision support. It could also include patient-generated data, which could be patient-reported outcomes or patient-specific data like labs or medications that we've been using in our decision support. And then also including social determinants of health and patient preferences that affect patients' individual health outcomes. Sometimes this decision support is delivered directly to patients via apps or patient portals. Sometimes it's delivered in the doctor's office, and it leads to this like a shared decision-making conversation, which is the last way these things can be used. And so that's our overview and definition of this. If I could go to the next slide, please. So just to remind you, it's got to be patient-centric, meaning that patient preferences are taken into consideration. Sometimes it's patient facing, which the information is sent directly to the patients. it should include the patient's context and history. I mean, all clinical decision support, that's our goal, but we're trying to do more of that and also include some of these patient preferences for how they want their care to be carried out and how they want their, things that they think about taken into consideration. And it should accommodate the patient's lifestyle and the clinician's workflow. And we've struggled with physician workflow and fitting our decision support in, and now we're trying to figure out how to fit clinical decision support into the lifestyle of patients. And so you want to make sure that information is sent to patients where and when and how they want to receive it. So for example, do I want it on my phone, or do I want an email, or do I want a text message, things like that. And then also we're thinking about stuff that's going to happen between the visits of care. So if you think about it, while we think the healthcare delivery system is important, even the sickest patients spend only a small minority of their time at the doctor's office or in the hospital. And so most patient care happens outside of visits with the healthcare system. We're trying to develop some kind of decision support systems that can help support the care between those visits. If I can have the next slide, please. And so here's some examples of patient-centered decision support. One could be something like an app that gathers patient blood pressure from an automated cuff that you have in your house, for example, and transmits it to providers. Might highlight some abnormal values that are based on the patient's care plan. So those should be individualized to the patient based on their age and their condition. Should show that to both the provider and the patient. And it should provide some kind of care plan recommended patient actions of these abnormal values. So like, for example, if you have a high value, you might be encouraged to, stop eating salty foods or go visit your doctor or something like that, depending on the abnormality. Call an ambulance if it's really bad. And so these apps have an important role to play in this while you're getting your blood pressure, because lots of people take their blood pressure, but you don't always know what to do with the different values you get. Another way to think about an example of patient-centered decision support would be an EHR integrated shared decision-making tool. So for example, an elderly gentleman like myself that's over 50 that and his clinician says that he may be eligible for prostate-specific antigen screening, and it comes up and they want to have a discussion with your provider about whether you want to have that screening. And so you'd want to know the pros and cons of that, and sort of the risks and the shared decision-making benefits. There might be a video that you'd get or something like that. So if we go to the next slide, I think I'm ready to turn it over to the next provider, which speaker will be James Schweiger from the Agency for Healthcare Research and Quality. Take it away, James.
All right, thank you, Dean. Good afternoon and good morning, everyone. So now I'm going to briefly go over AHRQ's PCOR Patient-Centered CDS Initiative. Next slide, please. So first thing, AHRQ's mission is to produce evidence to make healthcare safer, of higher quality, more accessible, equitable, and affordable, and to work with an HHS and other partners to make sure that the evidence is understood and used. And within that, our division of digital healthcare research is to determine how the various components of that ever-evolving digital healthcare ecosystem can best come together to positively affect healthcare delivery and create value for patients and their families. Next slide. So in 2016, we began our initiative based on patient-centered outcomes research, which was part of the Affordable Care Act legislative requirements, Section 6301. And it had two main parts. First was the incorporation of research findings, where AHRQ was intended to, in consultation with relevant medical and clinical associations, shall assist users of health IT focus on clinical decision support to promote the timely incorporation of research findings that we would disseminate into practice and promote the ease of use of that information. We also had a mandate to gather feedback. So we had to create that process to receive feedback from physicians, healthcare providers, patients, and vendors, and also look at the value of the information disseminated and the assistance provided in terms of all the projects. We're very fortunate that this was reauthorized in 2019 for 10 more years. So we have plenty more time to continue doing a lot of this great work. Next slide, please. So we transformed this legislative mandate into an overarching initiative that we represent with the 4 pillars below with 2 basic goals in mind. One was to advance evidence into practice through CDS, and 2, to make CDS more shareable, standards-based, and publicly available. So in the first column, engaging a stakeholder community, one of our first projects that lasted 4 years was a cooperative agreement, the Patient-Centered CDS Learning Network. And 2 important works that came out of that is they spent a lot of time defining the definition of patient-centered CDS. And another thing they did was they developed the analytic framework for action, which that is a framework that surrounds prioritizing, authoring, implementing, and measuring as it relates to getting the translation of evidence of patient-centered CDS into clinical practice. The other column, we wanted to create a prototype infrastructure for sharing CDS and developing it. And we did this through our CDS Connect program that has an authoring tool as well as a repository for any artifacts that are generated. One other area that we wanted to support this initiative is through our grant-funded research program. The last one, we awarded a contract to evaluate the overall initiative. And one of the key points, other than evaluating the initiative, we took a look at the horizon scanning and the future state of patient-centered CDS. And we also funded 2 pilot projects that you'll hear more about today. The bottom bar for the CDS Innovation Collaborative, that's one of our newest projects that incorporates all these pillars. So it has a stakeholder and work group component, and it also has an innovation center to test any of these products and concepts out in real world settings. If you want more information for any of these projects, please go to cds.ahrq.gov. Next slide, please. All right, now I'm going to turn it over to Dr. Boxwala to talk about PC-CDS standards.
Thank you very much, and hello everyone. Next slide, please. Thank you. So I'm going to talk about the standards and how they fit in within the whole realm of patient-centered CDS. This is a diagram from a paper that was recently published in JAMIA. So within this manuscript, we broke down the standards, sort of where the standards are needed into these 7 domains. So it starts with, first is standards for translating clinical guidelines, so the big PDF or documents or HTML documents or manuscripts into computer-based decision support knowledge to be used within that. So that's standard 1. The second one is standards for managing the data provenance. So with patient-centered CDS, there's a lot of data flowing from patients into apps, into EHRs, and then into other systems for quality measurement. So it's we need standards for that as well. Third is for patient-generated health data. A lot of patient-centered CDS depends on patients providing data. And so how do those data get represented? Fourth is the standards for how we can insert patient-centered CDS into workflows and into the patient's life flows, if you will. All right, so that's number 4. Number 5 is standards for non-clinical patient-centered data. So not just your blood pressure readings, but other things about the patient, right? And we'll talk a little bit about that. The last one is how do those patients, not the last one, the 6th one is the integration of how those patient-generated health data now get into the EHR. So what standards support that? And the last one is APIs that are available that can help CDS engines essentially provide better clinical decision support. Can we move to the next slide, please? Thank you. So a lot of this domain of patient-centered CDS, especially the kind of the more digitally enabled one, is relatively new. And so a lot of these standards that we're talking about now are primarily looking at the new FHIR-based, HL7 FHIR-based standards and the implementation guides associated with that. Right. So for the standards for translating clinical guidelines, can you click? I think there's some animation there. Thank you. So within FHIR, there are standards for representing knowledge. Plan definition is kind of the key one that allows you to create rules and order sets and such. And and that goes along with something called CQL, or clinical quality language. That's an expression language that allows you to specify, for example, the logical criteria within decisions. Click, please. And then within FHIR, there are, I think it's still evolving, but the standards for provenance, for example, there's a provenance resource, and then within the individual resources too, there are some metadata that can be used to capture the provenance of the data. Click, please. So PGHD standards, in FHIR, typically a lot of the patient data is reported through resources called observation and questionnaire response. Those are kind of the most common ones that you may end up using if you're going to capture patient-reported data with FHIR. And there are implementation guides. For example, there is a patient-reported outcomes implementation guide that uses that can be used to collect PROs from patients and then share them with other systems. There are lots of new codes being added to LOINC, for example, for associated with different PROs. So there's, for example, PHQ-9 has a representation, has codes within LOINC for each of its questions and the total score. Click, please. So in terms of inserting CDS into workflows and apps, CDS hooks is the emerging standard for that. And a lot of the CDS hooks, the triggers defined within that are right now more sort of triggers within the EHR for providers, and there aren't that many patient-facing hooks for patient-facing workflows. Click forward, please. In terms of non-clinical patient-centered data, we commonly think of social determinants of health, and there's a Gravity project that has created implementation guides for how FHIR can be used to record and exchange social determinants of health data. Right. Next one, please. So I mentioned earlier that observation and questionnaire response are the common sort of resources within FHIR that can be used to capture patient-generated health data. And I mentioned the PRO-IG. There's another implementation guide for data from personal health devices that can be used to integrate data from these devices into EHRs. And next one, please. Thank you. And then for CDS engines, for example, even for CDS hooks based engines, the way to get other patient data from EHRs or from other systems, there are lots of FHIR resources. For example, you can query an EHR to get the medication prescriptions for a patient, or lab results, or the problem list through various FHIR APIs. So that the CDS can be more based on a more comprehensive view of the patient data. Right. Next slide, please. Okay. So as you'll see, as we, in the next part of this webinar, David and Nita will talk about the pilots, and these are some of the sort of findings that overlap with those pilots. But first of all, there's a lot of energy and effort going on in creating these standards. Right? There's just many initiatives going on. You can see them in various blog posts, the FHIR, Smart and FHIR app session within the AMIA presentation, FHIR Dev Days, and lots of other places, and certainly within HL7 Connectathons, just a lot of work going on to create and mature these standards, right? But the standards are still early, evolving, that will require some more time to mature. So that means that not every requirement's currently met through standards, and sometimes these, the earlier, some of the resources that are not yet mature enough, they might change as you're working through a project too. So you just have to learn to adapt and be patient. As FHIR is the messaging standard, but the terminology standards, especially as regards to patient-centered CDS, are even further behind. So for example, representation of patient preferences, patient values, those are still lagging in terminology standards. They're rich in things like problem lists and medications and procedures, but things that like patient symptoms and patient-reported outcomes, those are still playing catch up. Now, as the standards get published, the health IT systems, EHRs, digital health apps need to adapt them, and certainly they'll always be, lagging behind the development and maturation of the standards. So those are still evolving. Those are still getting added, I'd say, pretty rapidly within the EHRs, but they're still a little bit behind. And then you'll find that there's variability across different systems that, one vendor's implemented one resource, the other one doesn't implement another resource, or there might be some variations in what they allow you to query, the query parameters and such. And there's still, there's within now we move to the next place, which is the healthcare organizations and their adoption of the functionality that their EHR vendors or other health IT system vendor provide is further lagging behind, and their sort of teams have to also get familiar with those skill sets of how to manage those APIs, and they need to open up their firewalls for sort of patient-facing apps, and all of that's still catching up. Having said all of those sort of things, I still think, these new standards have been tremendously helpful to us in our pilots and in our experience in other projects as well. It's just been, I think it'd be much, much more challenging to do it without having the interoperability support that these standards provide. And I think that was my last slide. We'll move to the next one, please. And I'll turn it over to Dr. Kashyap and Dr. Loback.
Thank you, Aziz. So David and I will tag team and talk to you about two of our pilot projects. One is relates to tracking COVID patients with symptoms and heart rate and pulse ox monitoring, and the other is monitoring postpartum moms on their blood pressure. Before I go any further, I just want to make sure I acknowledge my colleagues back home, without which none of these projects would have gone anywhere. The care coordinator team at Yale, who not only does the work of Angels, but also helps support our research mission as well. And my colleagues in the maternal fetal medicine, as well as cardiology department, who were involved in the second project. Next slide, please. I will cover the clinical rationale and the existing workflow over which we layered the PCCDS applications, and then David will talk to you about the challenges and lessons that we learned through those. He will also be doing some telepathic reading of my mind as he advances the slides on both of our behalves. We're going in the wrong direction, David. One more. Thank you. The goals for both of these pilot projects was to enhance an existing workflow where there was already a connection. So we were just trying to test the ability of another patient-centered decision support application to enhance the value that that can be brought. Also using this as a demonstration project to share some features of a PCCDS application and of course share some lessons along the way. Next, please. And the project spanned about 2 years, as you can see. Most of the time was, of course, in building, testing the applications, understanding the specifications, as well as doing some quick PDSAs after the launch. The first project was launched in May of 2021, and I will call that date out when you start asking questions about the nature of the implementation. The second pilot launched in February of 2022, so just very recently. Next, please. The clinical rationale for the COVID-19 tracker, it started back in the spring of 2020 when we were in the early stages of COVID, where we had just developed a testing mechanism for testing COVID. We had no outpatient treatment. There was no vaccine. We knew that patients would deteriorate after the first few days, and if they tided that over, they were likely to do fine. But early recognition with dropping pulse ox was a sign. So this program was developed where a group of care coordinators were assigned to manage patients who tested positive and were prescribed a pulse oximeter. Remember, we also did not have pulse oxes available on Amazon or your favorite pharmacy. We were FedExing these to patients at that time. The goal was to manage these patients outpatient safely and escalate care where needed in case of early findings of pulse ox. Next, please. The system started with identifying patients who would be eligible for monitoring by looking for anyone testing positive or having a prescription of this pulse oximeter. They would then receive a phone call to determine eligibility for home monitoring, and that the patient verbally accepted that they would comply with the requirements of this monitoring program. At one point, the care coordinators were managing about 200 to 300 patients at a time. Once enrolled, the patients would then receive a questionnaire through the patient portal, which would allow them to answer responses on heart rate, respiratory rate, pulse ox, and any additional symptoms. The care coordinators would then reach out to them based on symptoms or predetermined frequency at 5 to 7 days, and at the end of the program, around 10 days to release them from isolation. Next slide, please. Now, when we engage with the teams, they identify some themes on workflow challenges that they were experiencing, and we tried to solve them with existing tools as well as the PCCDS application, which we describe in the very right column titled Pilot Tracker. The themes are, and you'll hear them repeated often, patient need reminders to do the tasks that have been assigned. As a healthcare organization, David, there are some animations if you can follow along. Healthcare systems have staffing limitations, so anything we can automate would be helpful. For the clinicians, it's important to see trends, not just individual values. And of course, patients need some feedback in real time based on anything that they entered, as well as a way to escalate symptoms if something is noticed. We also had the additional challenge of managing several stable patients, and the effort to track them outweighed the benefit, whereas the patients who needed more hand-holding would otherwise be left behind. Next slide, please. So I'll walk you through how this thing looks in our EHR. Next slide, Dave. So starting with a work list, this was the list that our care coordinators used to identify eligible patients as well as to track patients as they enrolled in the program. The list was based on, as I mentioned, anyone who had a pulse oximeter prescribed or had a referral placed for this particular system. Next slide. You will see that in this work list, the very right column shows that the patients enrolled in a home monitoring program, and the bottom pane shows you that they have values that they've been reporting over a period of time that the team is able to trend. From this very screen, the team can, of course, document any phone outreach that they made. If you click one more time, you'll see the area where they can create something called an episode in our EHR, where they could enroll in this enhanced text-based monitoring program. One more click, David. And once they did that, the patient would then be enrolled in this additional text-based monitoring program, in which case, instead of getting a questionnaire on the patient portal, they would receive a text message. Next slide. This is a welcome message that the patient gets when they first enrolled. And then the next part of that shows you the link that they get sent to answer these questions. The link would be delivered via text message every day, and the patient was able to then answer these questions with some parameters built in for abnormal values to provide some directed decision support there. Next slide.
Thank you, Neetu. I'm going to pick up here and just talk about some of the challenges we've had with the integration process. I have the privilege of really talking about sort of the real world experience. And before I get into that, I do want to acknowledge the great work of Dr. Buckswala and the LIMU team, as well as our colleagues in Health IT at Yale, who really pulled this all together, and the collaboration of the vendor in this project, which was Epic. So just to start talking about some of the things we encountered as we tried to move forward, this ties back to what Dr. Buckswala was presenting about some of the standards, and they're not quite fully fledged yet. One of the first issues we had was to identify patients for enrollment. The standards for this we could have used would have been the subscription resource or the HL7 version 2 messaging, but unfortunately, subscription was not implemented in the EHR, and the HL7 version 2 was not implemented in our app. So we ended up using some EHR rules engine application in order to identify the patients for the enrollment. The next issue we faced was requesting or having a way to get to request to enroll a patient. There's really no standards available right now around this issue. So we ended up using CDS hooks and what was considered an off-label use by Epic in order to get a trigger to do the enrollment action. Third issue we faced was informing the patients that they'd been enrolled. The communication request resource would have been used here, but that wasn't implemented by the EHR. So we moved to using text messages, which actually worked quite well in engaging the patients. The fourth issue was authenticating the patient who would be using the app, and this could be done by Smart on Fire. But if we did that, it would require the patients to have a portal account and login credentials, and that could get sometimes cumbersome and become a barrier to use. So what we chose to do was to send short-lived links to a web-based intake form as a way to get the patients engaged to providing their data. Fifth issue was updating the patient data getting the patient data from the EHR to the app. And here, the available resources in FHIR would have been the patient, the practitioner, the observation resources. And when we set this up to work, as those were fully implemented, we ended up encountering a blockage that took us a while to figure out why these resources weren't working, but it was because there was a firewall that was blocking the connection between the cloud-hosted app and the internal client system. And we had to add an exception to the firewall to get around this issue. Next issue was going in the opposite direction. Here we wanted to get the patient data from the app to the EHR. The available FHIR resource would have been the questionnaire response and the observation resource. The questionnaire response was not implemented, and the observation resource was only partially implemented. So we ended up just using the observation resource, but we had to use proprietary codes because there wasn't a standardized vocabulary currently hooked up to the observation resource. And then the final issue I just want to touch on for this initial first pilot was the concept of alerting the clinician. Again, the communication request resource could have been used here, wasn't implemented by the EHR, so we ended up using a rule-driven system that we created within the EHR to highlight the flow sheet. And then as a backup, we gave advice to the patients to say, call the provider, and we provided the number for them through which to do that. So in summary, about these challenges, things we learned was that FHIR is evolving. There was a lack of a FHIR standard resource to request the ability to enroll in an existing service. And then we had other places where the implementation of several of the FHIR standards was lagging. As I mentioned, subscription resource for triggering enrollment, communications resource for sending the message to a patient or to alerting clinicians, and then the questionnaire response to get patient-reported data and patient-generated health data back into the EHR wasn't available. And then the observation resource to send the patient data into the EHR had some limitations because it wasn't fully implemented. We also ran into some issues with the current cyber security environment that would obstruct third-party apps from doing this type of integration. And some other key things that we took away is that having local champions were really critical for the success. We had a team that kept working with us through all these challenges and persevered. And then also this, just the skills for doing the FHIR integrated apps were needed in order to make this type of a process work. So what did we learn from this first pilot? Is we wanted to move on to a second pilot to sort of expand our learnings. And we demonstrated we could build an engagement app that integrated to the EHR. So we were successful. And it would have been a lot harder if we hadn't had the FHIR standards, but they were limited. We also found that we couldn't do kind of the ideal integration, but we had to work with what we had. So for pilot 2, which we're now going to present in more detail, the clinicians used tools that were built within the EHR, so similar to what we've done with pilot 1. So it was already something that was familiar to them, and we came into their workflows. Patients used an app that was not tethered to the EHR, again, using the texting. We shifted the patient enrollment to Smart on Fire app, and we replaced CDS hooks in the off-label use. The new app had more complex patient flow and patient communication, as you'll see. And then there was a more complex decision tree on processing the patient responses. So I want to turn it back to Neetu now so that she can pick up telling you about our second pilot project.
So blood pressure monitoring for new moms who've had pregnancy-induced hypertension, either new or known, is known to have detrimental effects. And monitoring blood pressure for those patients has been shown to improve health and prevent morbidity. Also, early detection of side effects and complications can prevent catastrophic illness in this population. It is also well understood that this population, although very motivated, may not be able to keep appointments or track their own health as well. They have little feet and big concerns to take care of. The system that our teams already had in place was patients who were identified in labor and delivery to meet criteria, also to meet eligibility criteria where they needed a smartphone, had some language preferences and other conditions that they met, were then enrolled in this monitoring program. Were provided a Bluetooth cuff to take home and instructions that you see here, as well as the necessary applications were downloaded on their phone by our teams. Moms would then be discharged at their stipulated time with these instructions, and also follow-ups arranged via phone or telehealth visit with our clinical pharmacist in the cardiology department to co-manage these conditions. The monitoring was in place for up to 6 weeks postpartum or increased if needed. Again, workflow opportunities, similar trends as you see in the themes listed on the left, and how we solve them either by existing tools within the EHR or through the tracker application for PCCDS. Again, patients need reminders. They have other things going on in lives that need attention. Clinicians need values to be intermingled, whether they're patient reported or clinic obtained, to be viewed. And of course, they'd like to see trends as opposed to just individual values. Patients need just-in-time feedback, as well as an indication if the symptoms or findings that they're entering are concerning enough and need to be followed up. The additional challenge, of course, that was with this application, as David pointed out, is that the monitoring was variable and individualized in some instances, but also within the standard protocol varied between week 1 and subsequent weeks as well. One more, David. Okay, so this should start to look familiar. We based the workflow integration as a single work list for all of those teams, whether it's to find new patients, which were in this case identified by means of a tag in the chart, as well as a referral order that was placed for this clinical pharmacist co-management program. Once the individual made it their way on the list, they would then follow a similar enrollment project workflow where there was a contact with the individual patient, and the patient would then be enrolled, this time in a Smart on Fire application that you see highlighted on your screen right from that work list. Once the user clicked on the application, the app was then launched as a window within the EHR. You can see the data that was brought in from the EHR, and it also allowed us to then enter a new mobile phone number that the patient may prefer for this application, as well as a start date and a preferred time that they would want those messages. And once those informations were entered, the patient would then be enrolled. Once enrolled, the patient would then get a, next slide. They would then get a text message, of course, the welcome message that you saw previously, accompanied by a link to then answer this series of questions that the clinical team wanted answered. These were powered by a decision tree that the team came up with based on current evidence-based guidelines. And once all of those questions were answered, the patient was then prompted to submit those answers and would be prompted with a confirmation screen as well as some recommendations. In this example, there were 3 abnormal findings. All 3 of them were deemed by the team to then be the ones that needed a call to the on-call team, and you'll see the number presented right here. If, however, everything was normal, the next day the patient would get another reminder to enter their blood pressure, and after a predetermined time interval where we didn't see any response, another reminder to enter that value. Next one. The actionable recommendations, we want to point out that while we did build it into the decision tree for the patient themselves to escalate, we needed a way to also respond to tag those along in the flow sheet that David had mentioned as values that when the clinician went to review, they can preview those and it's called out for them. Next slide. So in this screenshot, you'll see that Nancy is enrolled in the program. She's been sending blood pressures. We see 2 values. A couple more clicks, please. And then one of those value responses is abnormal and has a yes with a little grid icon next to it. David, back to you.
Yeah, thanks, Neetu. I just want to pick up again sort of what we learned from this pilot project, to sort of building on top of what we learned from the first pilot project. First is that this integration with the existing workflows, using the existing reports and things like we did, really facilitated adoption. It was a very smooth transition to start incorporating this patient-generated data right into the clinician workflow. So that was a real positive. The enrollment workflow needed some improvement, especially there was something we discovered is some people we'd want to engage and they might not participate, and we didn't know why they didn't. We really weren't able to keep track sort of the individuals who we wanted to invite but might have declined for some reason. The alarm escalation path is really critical for both the patient safety as well as the staff to feel that they're on top of things. Wasn't quite as robust as we might have liked because of some of the limitations, but we had the initial notice showing up in the reports, and then also the backup of telling the patients to call and engage the clinical team if there were concerning issues discovered, like significant changes in vision or bad headaches. We discovered that when we sent out the links to the patients, that sometimes patients didn't respond immediately and the links would time out. So we ended up having to lengthen the link, the time we gave the patient to respond to the link, because they might, they're busy, they have a new baby, maybe the next day before they're ready to engage in the process. We also had the symptoms were available to the clinicians, but it was really more of an on-demand. They had to go look up the other symptoms in the EHR, so it wasn't as ready of a workflow that we might have liked to have had, where it was a push capability for some of the concerning symptoms. We discovered that we had some version control issues that were somewhat subtle. For example, we had the system fully running in the test version, and we moved it to prod and it didn't work. And we discovered that this was related to sometimes the browser versions that were different, or some subtle differences in the FHIR versions that were being used. So just again, the reality check of actually doing this type of a project. We had a need for a text-based solution, right? That didn't need smartphones, because here we could only engage people who had smartphones, and then we recognized that that would be a little bit of a disparity. And then there's other issues like digital access, that would be a disparity, and then digital literacy. So there's some more that needs to be done in order to make this technology very broadly usable, but at least it was a start, and we were able to successfully engage patients to give us their blood pressures and some additional symptom data with the approach we described. It was very critical that we had the local IT expertise to do the integration and to test the Smart on Fire app in the clinical environment. And again, this familiarity with Fire and Smart on Fire is really important to set up these types of systems and could limit the future portability. And then finally, we needed a lot of collaboration with the EHR vendor, just really not plug and play, sort of a lot of back and forth, figuring out how to make this work at this stage in the game with the level of maturity of the Fire standards. That said, we were able to have a successful implementation and deployment of a patient engagement app, actually 2 apps that integrated within the existing workflows and relied on these new emerging interoperability standards from referred to as FHIR. But we are still in the early days with the standards, with their implementation, and the experience with their use in doing the integration of patient apps. We have pulled together a manuscript that summarizes this, and that's currently under review. And with that, I can turn it back to Dean to monitor the question and answer period.
Thanks so much, David. And thanks for a wonderful presentation from all of our panelists this morning. So we have several questions already in the question and answer box on the slide in addition to the chat. And if you want to have additional questions, please feel free to type them into the Q&A. I'll try to monitor them as we go. The first question I'd like the panelists to talk about is this one from Grace Glennon that says, excuse me, do any of the panelists have thoughts on how to overcome the FHIR implementation challenges that would ideally streamline some of these processes? I guess I'll start with David for that one.
Yeah, thanks. And I'm going to defer somewhat to Aziz since he was really, really deeply hands-on. I think it's just a matter of time and working with your EHR vendor to find out how, sort of before you start, maybe get a better sense of what is implemented and what is not, because we sort of did it as we went along and said, well, can we use this resource? Well, no, we don't fully have that implemented. So that would be my idea. And Aziz, anything you want to add to that from the deeper technical side?
And I'm sorry, I missed the question because I was busy answering another question. So
I was just trying to add, the question was about overcoming FHIR implementation challenges. And do you have any ideas to help us streamline some of these processes?
FHIR implementation challenge. I would just say that it's really your sort of EHR vendor specific issues. So you really need to work with your EHR vendors sort of support team to get those issues addressed. Test a whole lot, build a whole lot of sort of mock services on your side to be able to keep testing those. Is all I can say.
So while you're on, Aziz, can you tell us how long it took to implement these pilots? We saw the timeline sort of, but that was also sort of for the project as well. But how did that work out?
I'd say I think the COVID tracker, it took us about, I think from development to start of development to go live was about 6 months to build everything, build the app and do the integration and test the integration and turn on the on switch. And I'd say about 50-50, it was about 50% development time and 50% integration.
Yeah. All right. Thanks.
Mm-hmm.
So there's another question from Rita Torquezada. It asks about non-solicited patient-generated health data workflows be supported for patients to self-report data absent prompting, such as health system questionnaires. And I'll let Neetu try to tackle that one.
I will try to tackle that one. So we do have those, and they're typically the patient portal tethered questionnaires, where a great example, since we're talking COVID, was pre-visit COVID questionnaires. If you have any symptoms, where you go ahead and answer those, or if you've had a recent COVID test, you can put it in responses there. They're not solicited. They're not prescribed for a particular reason. So they're just there for you to answer. But again, through the portal, I'm not sure if we're there to step out of the EHR realm and have other applications sort of write to your EHR in that way.
Thanks. I see another question from Brent Sandmeyer, and this was something that's come up every single time we talk about patient-centered decision support. He asks about, was there any patient involvement in the development and evaluation of the pilots? And I'll let Neetu answer that one as well.
I get all the choicest ones to
Yep,
Jean.
exactly.
Sure. So our patient involvement is built into the project as part of the qualitative part of the projects. That we did solicit patients to participate in an interview. The COVID pilot, interestingly, and I will correct my mistake, I pointed out that we went live in May of 2021. Out in the Northeast, we were seeing our lowest rates ever during that time, and we ended up sunsetting the tracker program shortly after because of all of the other therapeutics and things that became available. So didn't have much of an opportunity to do a qualitative patient evaluation, but we do have that planned as part of this current pilot, and the team involved in developing the questionnaire that was part of the proposal with that intent exactly.
Thank you. I'll go back to David for one there. It says, where are these rules maintained? Or Z's, either one.
I'll take that. I mean, the rules are maintained within the app. So the rules for what data to questions to ask the patient, what to show them as responses, those are all maintained within the app, within the CDS engine within the app.
Yeah, there's been several questions now about sort of the ability to change the questions or change the questionnaires or things like that. And I think that, you know, in general, we're still at a pretty early stages with these patient-centered applications and apps, and it's still pretty heavily dependent on the developer, which is Aziz and his company, to make these changes in general, I'd say.
Yeah, and I'll add a sort of a answer to that these apps are not, I mean, you know, hard-coded to be just COVID tracker or postpartum hypertension follow-up, that you can use the framework to build other questionnaires, and it's you know, it's sort of extensible but customizable by the end user, probably not.
Yeah, one additional thing I will add is that while you can have the questions on the application, if you're looking to file those, write those back to the EHR, you need to create artifacts in the EHR, and then that's the piece, that integration that Aziz has been talking about.
Yeah, and I think that's going to be one of the big challenges. And so right now there was an earlier question about some of the vocabularies that are using, or the allowed responses from the different questionnaires. And there's some of those are already in the LOINC coding system. And I think as we learn more about the types of questionnaires that people want to ask to patients for patient-centered outcomes research, and we sort of standardize those questions, we'll standardize some of those answers, and we'll see those being in our controlled vocabularies as well. There's a question about authoring tools for the decision logic trees, and I know this is Aziz's favorite subject in the entire world, so I'll let him answer that.
Yeah, I will. So and I think the next question is kind of related. Our clinicians writing the CQL rules, and there was another question I answered already. So we have a open source CDS engine that we used within this project, and it's called A2D2. It's available from GitHub. Right now that engine supports a rule language called Rules. It does not support CQL, although I'm hoping this summer that'll change. And the authoring tool, Rules provides its own authoring tool for authoring rules. It has kind of different ways of writing them, and just like a if then else syntax kind of thing. There are graphical tools and rules and spreadsheets and all those things. We have clinicians writing the specs for the rules, and we have analysts who are not quite, like I said, not quite software engineers. They are trained in the rules language, and they understand some healthcare terminology and workflows and such, and they're the people who write the rules. The clinicians then end up reviewing the rules and testing them.
Yeah, thank you. That's wonderful. So we have one more question about the cost to budget in projects if you want to build some apps. I'll let you talk about that, Aziz, as long as you're on the camera.
Oh, thank you. So I don't know. I think this kind of is a it depends answer on a lot of things. I mean, it's on the complexity of the app, number one. Number two, what you already have in place for infrastructure. If you've done these, build 3 apps and you're adding a 4th one, it's it's much lower cost. All of those things. But this is. I mean, if you're going to, I think the cost goes beyond development to operationalizing this and hosting it, and all of those things are big deals. So I mean, in my experience, a lot of healthcare organizations don't have the ability to host a new app in-house. So they may think about either having the vendor host it or finding some place in the cloud. It's just like a modern apps I hosted in Docker, and you need to have all of those kind of things available, infrastructure available on your
Right.
side too. I mean, it's hard for me to give you a number right now. It's just
Thanks. I think that really covered it well. I mean, there's a lot of issues going on with this, and it's not, like you said, not just the development costs, which are probably small compared to all the other costs that you'll have
That's right.
to deal with in a project like this.
That's right.
We're at the top of the hour now, and I'd certainly like to thank all of our panelists for a wonderful presentation, and encourage all of you to think more about patient-centered decision support. Look at the ARC website to look at our patient-centered decision support CDS web pages. And thank you again for attending. We'll be sending out the slides to attendees, and we're still trying to find a place where we'll post a link to the recording of this seminar. Thank you once again. It's been great to be here today. Thank you very much. Bye.
Thank you.